Thank you. So I'll be sharing my slides. So I've been given the task of sharing the ASCO updates on the Rucaparib. The slides have been, this session is sponsored by Zydus. These are my disclaimers. So we'll move ahead. So Athena trial, yes, this was a very, very long awaited trial, and this is very important study for our real practice, because we know when a drug with a generic molecule becomes available, we try to get data which is by which we can justify the use of a molecule which is available to a larger number of patients. And with the availability of this data, it's definitely much become more easier to use this drug now. So this is a randomized trial, phase 3, evaluating Rucaparib monotherapy versus placebo's maintained treatment following response to first-line platinum-based chemotherapy in ovarian cancer. And these are the backgrounds which I have just covered already. So this was used in ENGOT member countries, GOG, and other participating countries. So multiple countries were part of this trial. So if we see the genetic biomarker status of the enrolled patients, there was close to 540 patients were enrolled. 50% were HRD negative, 25% were HRD positive, BRCA wild type, and 25% were BRCA mutant. So this is a very, very good pie chart with very, very good distribution, 50, 25, 25. So easy to remember. And this has been done on the Foundation 1 CDX by Foundation Medicine. So this is a very well established lab from which is has got high quality, so it is very good. And this that means at least 50% patients are HRD positive, which includes 25% having BRCA mutant and rest 25 BRCA wild type but HRD positive. So in this study, actually there were a nivolumab arm as well, where Rucaparib was administered along with nivolumab, and under arm B, around 400 patients received Rucaparib alone. In arm C, it was nivolumab alone, and arm D, it was both were placebos. So we'll see the study analysis of Athena mono and Athena combo. The Athena mono, that means Rucaparib versus placebo. On Athena combo was Rucaparib plus nivo versus Rucaparib alone. So these are these patients of stage 3-4 high-grade epithelial ovarian or primary peritoneal were enrolled. Patients had completed frontline platinum doublet chemotherapy and surgery. And the stratification factor was versus BRCA mutation versus BRCA wild type with high LOH, BRCA wild type with low LOH, and BRCA wild type with LOH intermediate. So loss of heterozygosity was taken up, and this was given a high importance. And this is what we have already discussed. Patients were continued on the treatment for 24 months or more till progression or till toxicities, and then after 2 years. So this is the baseline characteristics. Since it is a very well conducted randomized trial, patients were balanced in both the arm, HRD population group versus intention to treat population group. Significant proportion of the patients were PS0. However, in real setting, most of our patients are PS1 to 2 at presentation. Definitely in trial setting and in Western setting, more patients are in the PS0 situation, which is not very common in the real world scenario. But yes, we know the benefit will be there in both PS0, PS1, and PS2. The quantum might be somewhat different. And definitely, as happens in most of the scenarios, around 80% patients in all the patients were around epithelial ovarian cancer, and 10 to 11% are fallopian tube cancer, and rest 5 to 6% are primary peritoneal cancer. So in our setting also, we find 85 to 90% to have high-grade serous ovary, and 5 to 10% being primary peritoneal or fallopian tube cancer. Per se, primary fallopian tube cancer, usually it is difficult to identify because usually the patient have a significant disease burden, and the site of origin is difficult especially in stage 4 patients. If we see the HRD positive group, this is what I have just highlighted. Most of the patients were HRD BRCA mutated, around 50%, and rest were BRCA wild type but LOH. So it is. And if we see the data of Athena mono, that is median PFS in HRD positive patients population, if you can see the stark difference in the outcomes at 1 year, 47% versus 73.8% progression-free survival, and this was persisting at 2 years, 35% versus 55%. So a significant 20 to 25% improvement in PFS at 2 years. This is what we want to look at. If we see, this was investigator-initiated study, and this was the site blinded independent review. If we see the all-comer patients studied, it is again at 2 years 25% versus 45%, and it is the value hazard ratio is coming to 0.47. So this is another study where we need to understand the hazard ratio is going below 0.5. Hazard ratio below 0.5 means a study where the treatment is causing a very extraordinary difference in the outcomes, and this is study is one of those, hazard ratio of less than 0.5. If we see the various exploratory subgroup analysis, which are very important to understand, if we the HRD positive with BRCA mutated and BRCA wild type with LOH high, this is what we wanted to know. In here, if you would like to see, the difference is very stark in BRCA mutant. We all know this. The efficacy is we all were well aware. In this patient group, it will be the maximum benefit. Hazard ratio is 0.4. But if we see BRCA wild with LOH high, it again hazard ratio is not so bad. It is hazard ratio 0.58. So the most of the time the drugs get approved with hazard ratio below 0.8, and here it is 0.58, close to 5 only, 0.5 only. Yes, in BRCA mutant, it is extraordinarily good, 0.4, but it is very good. If we see the HRD negative subgroup also, the hazard ratio 0.65, but if we see the median, it is not so encouraging, but it is worth considering this difference in oncology as well, because drug get approved most of the time, even when difference is 1 to 2 months also, but it can cause significant improvement in the quality of life. So HRD negative, 9 versus 12 months, the difference is not so stark in terms of separation of the curve, but still hazard ratio is 0.65. It can be considered in this HRD negative as well. But yes, the quantum of benefit, which we know from the time of Niraparib also, Niraparib is also approved regardless of the treatment HRD test or BRCA test. Similarly, we are finding difference in the benefit is different quantum wise for the different subgroups. This is the similar groups were found on the blinded independent review. So it is demonstrating benefit irrespective of the BRCA mutation or HRD sensitivity. So all the groups, you can see the curve is toward the forest plot is toward the left in favor of Rucaparib. That makes us sure that yes, this drug is going to benefit a large number of the patient. Almost all the patients who get enrolled in this drug get treated with drug will get benefit with Rucaparib. So yes, it is beneficial. If we see the confirmed overall response rates in HRD positive group, you can see it is close to 60%. Intention to treat, it is close to 50%. And duration of response, yes, it is crossing 20 months in most of the patients. So this is an important point. Yes, the toxicities, we have now experience with Olaparib and Rucaparib, a large number of experience at our center as well. And our data of our more than 50% patient, 50 patient is under preparation and publication. Yes, PAR parameters are somewhat toxic, but it can be managed well. The toxicities can be managed by maintaining the doses in a very intelligent way. You can reduce the dose, you can check the CBC and LFT timely. So never ever when you start the treatment initially for 3 to 4 months, these are more critical time. It is should be aware, and we should be very careful in this time. Don't give a prescription for continuous 2 months, 3 months, because this patient can cause significant amount of anemia, thrombocytopenia. So at least at 10 to 15 days initially, do CBC and LFT so that transaminitis and anemia, thrombocytopenia can be taken care of. Other important side effects include diarrhea, abdominal pain, and nausea. But it is very important that the problem of anemia, thrombocytopenia, and transaminitis, these three are the most important problems. Others are usually well managed if these are well controlled. These are the lab parameter. Yes, the initial part you need to, as I told, the initial first 3 months are very crucial to maintain the toxicities. After that, it becomes stabilized, and you can see this is maintained very standard, very straight curve. So yes, and dose intensity. If we see what was the dose intensity level, so 3 dose levels were there around 500 milligram BD at dose level -1. -2 was 400, -3 300 milligram BD. In fact, in real practice, I think 600 milligram BD, I'm not very comfortable at starting this dose. However, it is personal preference for the physician what dose is to be selected. But there are options to start at lower dose and later titrating it up. Also, there is an option starting at higher dose and titrating it down with the toxicity. It is as per the physician experience. But if we see the data around in 50% patient, there was requirement in the dose adjustment. And but yes, a lot of patients can continue with full dose in the Western patients. We need to see our own data so that we need to understand what dose is best tolerated for our patients, and this Western data cannot be used for generalizability on our patients. If we see the scores, the factor score is a score to measure physical, social, familial, functional well-being, and it is preserved as same as placebo. So this gives us more confidence that if the toxicities can be managed well, you are able to preserve the quality of life of these patients. So this is important. So to conclude from this data, it is first-line maintenance data significantly improves progression-free survival irrespective of HID status. Yes, quantum benefit will be different for different subgroups. And patients with measurable disease at baseline have further tumor reduction with Rucaparib. So, and Rucaparib safety profile is consistent with prior studies, and we are now well aware of the toxicities and how to manage them. OS is immature at present because only 25% event of death has occurred till now, and we need to await further data for OS. But definitely, any drug which is causing hazard ratio of less than 0.5 is definitely going to have significant impact on the oral survival as well. So moving further ahead, this is the data of open label study where Bev, Atezo, Rucaparib were utilized. Patients received combination of Rucaparib, bevacizumab, and atezolizumab. This was a 30-patient subgroup analysis with primary goal of overall response rate. And this is a patient for recurrent endometrial cancer, which are not amenable to curative treatment or surgery or radiation after 1 or 2 lines of therapy, were eligible regardless of the histology. So yes, this is studies for recurrent endometrial cancer, which have been received 1 or 2 lines of treatment. So the CR rates is around 4%. That means one patient had CR, partial response was seen in 40%, stable disease in 57%. PFS is around 5.3 months. So some amount of responses. This combination may be safely used, but definitely we'll need to see further data in the phase 2 and phase 3 studies. This is an initial phase 2 data. So there's data of pembro plus lenvatinib already in the endometrial cancer, and we are utilizing that combination also in selected patients. So this data, yes, it can be considered in some amount of patients, but yes, we need to await more data actually for utilizing in our practice. And if we see the data of the post hoc analysis of the ARIEL 3 data, where the platinum sensitive patients were not associated with homologous recombination deficiency, it was performed to assess the efficacy of Rucaparib maintenance in a subset analysis based patients who had responded to platinum based treatment but were HRD negative. So patients were randomized to receive Rucaparib to 600 milligram BD versus placebo 2:1 ratio, 100 plus patient in arm of Rucaparib and around 50% in arm of placebo. And yes, you see the patients had received prior bevacizumab in around a large number of the patients, and prior number of platinum treatment as well. In all these groups, the patients had hazard ratio of 0.6. The patient who had response to last platinum, yes, the hazard ratio is to the tune of 0.44. So yes, it is important. Platinum response itself confirms sensitivity to PARP inhibitor. This we all know from a long time, and we should take this some question in very important. So yes, so in maintenance treatment in platinum sensitive recurrent ovarian cancer, it is clear that even patients who are HRD negative will continue to benefit from the drug Rucaparib. So in the current setting, in fact, you do not need to test for BRCA for utilizing this drug. But yes, if BRCA has been not tested as a germline testing, it should be tested because it is for the implications for family. It is important. So we try to have a dedicated genetic clinic in our hospital, and we have started the same with great enthusiasm. So maintenance therapy will Rucaparib lower the risk of progression in ovarian cancer patients, irrespective of presence of either BRCA mutation or HRD in patients who responded to platinum-based treatment in recurrent setting. This is the Atlantis study, metastatic urothelial cancer patients with DNA repair deficiency. So Atlantis is a multi-arm study. There are multiple arms of this phase 2 data basket trial. Actually, these patients included urothelial cancer who were biomarker positive for DNA repair deficiency. The patients had achieved either stable disease, partial response, or CR on first-time platinum-based treatment. They were randomized to receive Rucaparib maintenance versus placebo. This actually placebo arm was later dropped when avelumab became standard of care in these patients. But yes, this is the arm which was there. So primary endpoint was PFS and second endpoint was overall survival. And if we see the out of 279 patients, 248 patients were screened. And if we see the baseline characteristics, it was, yes, well matched between the two arms. There was some numerical improvement because this is only 20 patients in the two groups. And there was some improvement in terms of PFS with maintenance Rucaparib versus placebo. So there was a confirmed objective response rate or partial response in one patient in Rucaparib, but others there was mostly stable disease and progression free. So hazard ratios though reaching 0.53, but the problem was that this was a small subgroup, small groups which was analyzed. So this is considered as a exploratory option, not a standard of care option till now. So the Atlantis trial, the safety is again similar, median duration, no treatment related deaths were observed. So this study, the investigator concluded safety, this patient were found to have somewhat improved PFS data. It was 15 weeks versus 35 weeks, but this is based on only around 40 patients. This was not statistically significant, and concluded that results support further study of PARP inhibitor in biomarker selected patient. Yes, so in biomarker selected patient, the further studies needed to consider Rucaparib maintenance in the treatment. So with this, I stop here and would like to take any questions if there are.
Akhil sir, kindly check your inbox. Chat box question has come.
Okay. So should I take the question directly?
Dr. Akhil, so Dr. Rajat have two questions. So one is, are you comfortable with 4:1 randomization in this clinical trial? And second question is whether you will be using, so this is a question from myself also, whether you are comfortable using Nupar for oral patients who are HRD negative also, so you don't find much difference. And one important question, so do we now get away with the bevacizumab in this line? Is the Nuparp and Olaparib only option for our patient, or we still have some option for bevacizumab in this setting?
So first question about the 4:1 randomization. If the trial is enough powered for so much of arms, definitely it is fine for me. So 4:1 randomization, I will be comfortable if the statistical analysis is powered enough to answer that. Because if we are doing 4:1 randomization, there will be different arms and there will be different subgroups which needs to analyze. But this is all the work of statistics, and we can clearly see the difference in the survival curves, which is a clinician can easily interpret. The patients are getting benefit. This is very clear. How much amount of benefit? This is also clear. In the different subgroups, the benefit, the quantum of benefit is different. So if I have to use the group where the patient is having maximum benefit, yes, I will be pushing the patient to receive the same. But for example, if we take the HRD negative group in the upfront setting, the quantum benefit is small. Median is prolonged from 9 months to 12 months. So in this subgroup, I might not be too much comfortable. And also in such cases, what we can do is actually we can explain the patient this is the limited benefit option, and the patient might select, because the difference which might be less for us might be more for the patient perspective, and the patient has to take the final decision. But yes, our enthusiasm will decay when the patient are HRD negative, especially in the first line maintenance setting. In second line maintenance, yes, hazard ratio is very good. So in the second line, recurrent setting, platinum sensitive, patient receive platinum, you can definitely utilize Rucaparib irrespective of testing very comfortably, and we are very sure that it is one of the best treatment in that scenario. With what is the status of bevacizumab now? So bevacizumab has a different role, which is completely different from PARP inhibitor actually. So if you have to use one of them, it is definitely PARP inhibitor. But definitely we know some patients have too much amount of ascites or pleural effusion at the baseline. These patients actually require some bevacizumab as well, because PARP inhibitor is working on a different pathway, but bevacizumab is acting by VEGF mechanism, by which the amount of fluid secretion and endothelial mechanism is downregulated. So if patient had significant amount of ascites or pleural effusion at the baseline, I would be happy to use combination in those patients, but it is not for all patients, and or not all patients can tolerate the toxicity as well. So selected patient can utilize both. The role of bevacizumab has definitely decreased somewhat because of availability of some better options, but it has not completely gone.
So I agree with you, Dr. Akhil, and I think bevacizumab still has a role to play, at least in those patients who are inadequately cytoreduced or have heavy burden of the disease. In particular, if you are using bevacizumab in this line, will you combine it with Rucaparib or Olaparib? So we don't have data for Rucaparib at the moment in combination with.
So if I have to ever combine with Rucaparib plus bevacizumab, I will take a written informed consent from the patient. That patient has been explained that this is not a standard option, but it can be considered if the patient is not affordable for Olaparib in very selected group of the patient. So this has to be taken in a very informed consent. So because it has medical legal issues.
So I think our flow chart goes like this. Our patient undergoes a cytoreduction followed by chemotherapy in form of paclitaxel and carboplatin, and we are doing HRD for all our patients now. And if they have HRD positivity, we go for Rucaparib. If they have HRD negativity and a heavy burden of disease, I think Olaparib plus bevacizumab is an option. And if HRD is negative and the disease was adequately cytoreduced and there was no residual disease, I think the observation makes sense in these patients. Is it what we understand now?
Yes, this is a nice generalization, and this is definitely one of the best possible algorithm for now.
Thank you so much, Dr. Akhil. Dr. Rajat, do you have any questions?